So we look at diffusion, flare, match and mismatch concept. We look at concept of infarct core volume and how it has impact on the outcome. Then we look at CT a collateral scoring system, the single phase type and multiphasic type, and understand how it is important in understanding the stroke. Then we look at role of MRI in hyperacute stroke and its advantages over CT. Then we'll try and understand how ASL is as good or probably better than CT perfusion. Then we look at new DAWNS criteria and the continuously changing paradigms that happen as far as stroke treatment is concerned and how it impacts the imaging as well. Then we look at new aspect scores for posterior fossa and MRI aspect scores. Then we look at 4 predictors of post-thrombolysis hemorrhage and how we can caution the neurologist or neurosurgeon treating these patients with hyperacute stroke. Touch upon plaque imaging, although it's a different topic altogether. Then we look at how Sion imaging has changed the way we look at stroke patients. Understand DKI, which is upcoming and better method than the standard diffusion imaging. Look at PH-MRI, which is again experimental, but will change the way we look at stroke and the stroke ischemia, penumbra, oligomia, etc. And then last but not the most important, AI in stroke imaging and how it saves a few seconds, a few minutes when you're treating patients with hyperacute stroke. Let's start with stroke. When you talk about stroke, there are 2 broad subtypes. 80% strokes are ischemic and that's what I'm going to concentrate on. Mitusha is going to take the rest. 10% of these patients who present with stroke present with parenchymal hemorrhages, 6% have subarachnoid hemorrhage, and 4% are stroke mimics, typically subdural hematomas, hyponatremia, or something metabolic, which clinically presents like stroke. Let's understand the stroke definition. It indicates reduced blood flow and perfusion in the brain caused by a thrombus, embolus, or hemorrhage within the vessels or outside the vessels. There are 3 zones which are identified when we look at infarct. The ischemic core, where the blood flow goes down below 12 ml of blood flowing through 100 grams of brain per minute. Penumbra is an area where the flow is between 12 and 20. Oligomia is an area where the flow is more than 20 but less than 50 to 60, which is normally present in a human being. There's a saying which says that what you want is what you get, and evolution of stroke imaging is completely reflective of this saying. For decades from where CT came into picture in 1973 and MR came in 80s, neuroimaging in stroke was done to exclude hemorrhage and stroke mimics. So when you did it really did not matter. About 20 years back, efficacy of thrombolytic therapy came into neurology, and that really changed the way we do neuroimaging in patients with stroke. And for us, we treat about 200 stroke patients in a year. It's race against time. We have what is called as code white. Mitusha will probably explain to you that a little later. So role of neuroimaging has now completely changed from pure simple anatomic depiction of infarct to identification of region at risk of infarction, detect the cause of stroke in the given time that you have, about 10 minutes on MR and few seconds on CT, and predict the outcome as well if it is possible. Goals of imaging in patients suffering from stroke are 2. Goal 1 is exclude primary intracranial hemorrhage, and 2, characterize if the patient has the stroke. That means you identify the core, quantify the core volume, and image the penumbra and pile collateral vessels, which are important because that actually comes out with the quantification and the outcomes of the stroke patients. There are 8 questions that we need to answer in the given time, and the given time is very, very less. Whether you have an infarct in patients suffering from clinical stroke, what is the cause if there is infarct, is it reversible, what kind of intervention is important, when it can be done, what is going to be the outcome if we thrombolyze these patients, can we predict post-thrombolysis hemorrhage or not, and can we detect upcoming stroke before it happens. That's not really in acute stage. Let's try and understand and answer the first question first. Is there an infarct? For this, across the world, a plain CT is still the most commonly performed study because it has 100% sensitivity to detect parenchymal hemorrhage, and it's quick and widely available. In today's world, where you're trying to thrombolyze or thrombectomize the patient, is that really enough? The answer is no, because 60% of patients who have had hyperacute stroke would show normal plain CT scan. So you'll have to look at something else. That means CT perfusion or CT angio. 40% of the cases where CT scan is positive in hyperacute stroke, you'll have to have a look at artery, typically middle cerebral artery. So you have to look at dense MCA sign, obscuration of lentiform nucleus, and insular ribbon sign. And these are the three telltale signs. Insular ribbon sign, where insula is darker compared to the normal side. Here, hypodense basal ganglia sign, where the basal ganglia have become darker compared to the contralateral side, and dense artery sign. There is acute thrombus in the right middle cerebral artery. MR, on the other hand, compared to 40% of CT, 97% with diffusion would be positive in first few hours. Other advantage of MR is it acts as one-stop shop to decide and evaluate tissue viability and vessel patency in one go. It is also good for hyperacute lacunar infarcts and posterior fossa infarcts. The other advantage with Sion coming in is it can rule out hemorrhage and microhemorrhage, and they're better detected on Sion than on CT scan. We do what is called as 11 minutes hyperacute stroke imaging. The sequence is diffusion, all of us know that because it identifies the infarct. Flare is important in patients who have a awake stroke. That means you don't know when the actual stroke happened. When patient gets up, he or she gets up with stroke. So flare is important to identify the onset of time of cerebral ischemia. HWI we know, look at microhemorrhages and hemorrhages. Perfusion, typically we do ASL, is to identify and differentiate infarct core from penumbra, and angiography to show acute thrombus at the given site. Here is the concept of flare match and mismatch. Two patients, this patient is flare positive, so can't be treated with intravenous thrombolysis. Here is a patient who's flare negative, so it can be treated with intravenous thrombolysis if required. Concept of infarct core volume. Typically, the cutoff is 82 ml of infarct core for the patients who need to be treated with intraarterial or intravenous thrombolysis. A large core has poor outcome, cutoff is 100. Smaller and moderate sized cores would have better outcomes, and this is highly specific indicator of malignant middle cerebral artery infarction versus a non-malignant middle cerebral artery infarction. The second question that we need to answer is what is the cause of given stroke, and for that you have combination of CT angio and MR angio. CT angio we know happens in few seconds. It shows calcified versus non-calcified narrowings much better. With multiphasic collateral scoring system coming in, CT scan, a CT angio has got even better. Just for our information, if you have absent collaterals covering more than 50% of MCA territory, it is considered as score 0. More than 50% territory is, less than 50% territory is considered as score 1. Diminished collaterals which are equal is score 3, and increased collaterals is score 4. And score 0 is considered as malignant profile, and these should not be treated with thrombolysis. With multiphasic CTA collateral scoring system coming in and CT scans getting faster and better, this has become more accurate, and differentiating good collaterals from intermediate collaterals to poor collaterals has become even better. MR angio does not have that advantage, but in the given scenario, with the other 4 sequences that we talked about, this can be a make-do solution where acute thrombus and acute occlusions can be shown in circle of Willis as well as in neck vessels. The third question that we need to answer is what we are seeing, how much of it is reversible, and for that you need to know concept of perfusion imaging. Ischemia is defined in brain when cerebral blood flow drops below 18 to 20 cc's of blood flowing through 100 grams of brain per minute, because that is the minimum that is required to maintain basic cellular activity in the gray and white matter. When it drops below this and remains there for more than between 4 and 8 minutes, you get infarct, which is permanent damage to the brain parenchyma. Perfusion imaging uses this to differentiate ischemic core from ischemic penumbra. Ischemic core is an area where cell death and membrane failure, sodium-potassium membrane failure, has already happened. Ischemic penumbra is an area which is marginally perfused, metabolically unstable. No cell death has however happened in this area, so it is the potentially salvageable brain parenchyma if you try and get this area reperfused by thrombectomy or thrombolysis. And here are two examples. Example 1 is where ASL showing large area of hypoperfusion and diffusion showing multiple hyperacute lacunar infarcts. So if you treat this patient with thrombolysis, the outcomes are going to be good. Compare this with the next patient where diffusion abnormality is about 110 cc's and perfusion abnormality is about 130 cc's. So if you thrombolyze this patient is likely to bleed and hence is a contraindication for thrombolysis. The fourth question that we need to answer is what are the kind of interventions which are possible in the given patient. So you have intravenous thrombolysis, which happens in 3 hours. You can have intra-arterial thrombolysis or thrombectomy, which can happen in the supratental compartment up to 6 hours and up to 24 hours in the posterior fossa. What you need to know is things are constantly changing and you need to look at the newer DONS criteria. Here is a patient done in our hospital. DSA, MRI had shown hyperacute infarct in right MCA territory. DSA is showing complete occlusion. Post-thrombectomy, post-removal of the clot, circulation has come back absolutely normal. The fifth question that we need to answer is when it can be done. I talked about it. DON criteria is what is followed and they publish this virtually every year or every 2 years as to what can be done. Currently, as I said, 3 hours have been extended to 4.5 hours for intravenous therapy, and in the posterior fossa, people are now trying to go beyond 24 hours as well. The sixth question that we need to answer is when you see an infarct, what are the likely outcomes? What we need to know theoretically is it depends on location of the thrombus. So basilar artery has mortality of 90%, terminal ICA occlusion has mortality of 50%, MCA territory, proximal M1 has mortality of 30%. So depending on where the thrombus is, mortality and morbidity is going to be different. Also, it depends on where the stroke is located, where the thrombus is located. Major CVAs, which form about 35% of all the strokes, have the worst outcome because they are called as large vessel occlusions. Compared to that, smaller vessels and acute lacunar infarcts have much better outcome. The other important aspect of understanding the location and size of stroke is what is called as Alberta Stroke Program Early CT Score. So it divides MCA into 10 zones, and wherever you see hypodensity, you remove 1 point from there. Anything less than 7 has bad prognosis. Score of 7, 8, 9, 10 has got good prognosis. This is quite accurate when you are using CT for early detection of stroke, and it's so accurate that now it has been put on MR and also put in posterior circulation. So this is added about 3 years back, and it divides posterior fossa into thalami, occipital lobes, midbrain, pons, and both cerebellar hemispheres. Again, the outcome depends on what the score is. Also, there are multiple clinical variables which impact the outcome. It's not only CT or MRI. It depends on time to treatment, post-thrombolysis hemorrhage has happened or no, size of the stroke, age of the patient, race of the patient, weight of the patient, and blood pressure at the time of presentation. The seventh question that we need to answer is, can we predict post-thrombolysis hemorrhage? That is very important question because you're trying to help the patient, and if it is going to be counterproductive, you should defer doing it. And this has 4 or 5 ways of making out whether the patient is going to get thrombolysis or no. Before we look at that, we must understand the ECAS 2 classification of post-thrombolysis hemorrhage. H1 is petechial hemorrhages located at the periphery of the infarct post-thrombolysis. HI2 is petechial hemorrhages which happen throughout the infarct, not at the periphery. PH1 is where you have large infarct with hemorrhage occupying less than 30% of the infarct post-thrombolysis, and PH2 is where involvement is more than 30%. Now, can we predict this before we thrombolyze the patient? Answer is yes. The most important predictor, predictor 1, is the size of infarct. So anything that is large in size, we talked about it, 10 ml versus 100 ml versus plus 100 ml. The chance of hemorrhage in infarct like this is almost 95%. Second predictor is location of infarcts. Gray matter involvement indicates that these patients are likely to hemorrhage because these are often due to large artery occlusions. White matter infarction would have lesser risk of post-thrombolysis hemorrhage. Aspect score we talked about. Anything less than 7 would have higher chances of hemorrhage. Third predictor is looking at the core of the infarct. If the core is large, like in this patient, this is core, this is perfusion abnormality. Chances of hemorrhage are high in that particular area. Next is predictor on DSA. So if you see good pile collaterals, then chances of hemorrhage is 2.7. If you have poor collaterals prior to thrombectomy, chances of hemorrhage are almost 1 in 4. And here is a borrowed patient where there is terminal ICA occlusion, poor collaterals on the affected side, thrombectomy done, patient bled. Compare this with the next patient, again borrowed image, proximal M1 occlusion, good collateralization, thrombectomized, opened up the artery, no hemorrhage. The last question that we need to answer is, can we detect upcoming stroke before it happens? For that, we must understand the concept put forward by Nasset in 1986, which talked about efficacy of carotid end. There was no stenting then. So efficacy of carotid endarterectomy in patients who have carotid narrowing of between 70 and 99%. It was conducted across 14 countries, and it was decided that anybody who has narrowing between 70 and 99 should undergo carotid endarterectomy, and then the outcomes are better than patients who are put on antiplatelet therapy. Over the last 15 to 20 years, the new researchers have realized that that does not really hold true today, because stroke genesis, unlike heart attacks, is not low flow related. In fact, 75% of the events happen when you have carotids which are moderately narrowed, that means less than 50%. And this concept led to research going on to what is called as vulnerable plaque versus culprit plaque, and that is based on plaque classification which was modified by American Heart Association for coronary arteries. So American Heart Association divides plaques into 8 subtypes: normal, diffuse or focal mural thickening, lipid-rich plaque with necrotic core, hemorrhagic plaque, calcified plaque, and fibrous plaque. Out of these 8 plaques, plaques which have high lipid content and which have hemorrhagic content are considered to be more unstable plaques, and those are likely to rupture and go to brain compared to calcified or fibrous plaques. Basis that, you have high resolution MRI and high resolution Doppler to look at the narrowing of carotid and characterize the plaque. So we do FATSAT T1, FATSAT T2 and contrast to see the plaque morphology and the contents of the plaque. And it works very well, not of course in hyperacute stage, but in acute or subacute stages to look at ulceration in the plaque, hemorrhage in the plaque, etc. So what is the current status as far as treating hyperacute stroke patients is concerned? Researchers are moving from wall clock-like situations like cutoff of 3 hours or 6 hours or 24 hours to understanding the tissue clock. So we need to identify the group of patients who will benefit from thrombolytic therapy and increase this group. So you have what is called as hyperdense MCA sign involving less than 1/3 of MCA territory, which can be treated very, very actively and very well. On MRI, if you see microhemorrhages or leptomeningeal enhancement, that is a contraindication for treating patients even if they come in hyperacute stage. There are researchers who are proponents of MRI. They say do a 3 or 4 minute MRI, then give bridge therapy, give half the dose of thrombolysis, complete the MR and come back and do thrombectomy, etc., depending on what is available and what is possible. But if we look at ACR guidelines, it still says that CT angio is probably better than MR for looking at hyperacute strokes. There are several new modalities which are coming up on MR which hold a strong promise to refine further this subset of patients and improvise patient management and outcome. So you have ASL, you have Sion imaging, you have diffusion kurtosis imaging, you have PH-MRI, and you have what is called as rapid AI to detect these patients early and treat them well and further subclassify and identify patients who would benefit with thrombolytic or thrombectomy treatment. ASL we know is very, very useful in evaluating penumbra zone and looking at diffusion-perfusion mismatch very accurately without having to inject contrast. It can also look at the thrombus very well. Here is an hyperacute thrombus in right MCA or terminal ICA. It is also useful, you can repeat it many times, in a post-therapeutic hyperperfusion situation. So you know that this particular patient who had large diffusion defect, lot of it has reversed back on diffusion on post-thrombolysis MRI, and that area is hyperperfused on ASL imaging. Swan we saw is useful in looking at microhemorrhages, but also it shows acute thrombus very well, what is called as susceptibility vessel sign. So acute thrombus appears larger than the contralateral artery. It is also very, very useful in looking at, if you have not done diffusion, this is good enough to look at prominent vessel sign, and this area corresponds very well to diffusion abnormality and perfusion abnormality. Diffusion kurtosis imaging is a better invention compared to the standard diffusion imaging. Standard diffusion uses what is called as Gaussian distribution of water diffusion. Diffusion kurtosis looks at non-Gaussian distribution of stroke abnormality. And here is an example. This is again borrowed. You have a patient with posterior watershed hyperacute infarct. Follow-up shows that the diffusion kurtosis abnormality has become scar. Diffusion abnormality has got reduced quite significantly. So diffusion kurtosis imaging identifies core much better than the standard diffusion imaging. PHMR is based on the principle that even before the ASL or diffusion abnormality comes in, pH in the infarcted area drops and it precedes the CBF abnormality. So using that, the researchers are now looking at dividing the area of infarct into 4 zones. So you have combination of diffusion kurtosis imaging and pH imaging. We currently divide diffusion and perfusion abnormality in zone 1 and 2. This can be further divided into kurtosis lesion, which is actually going to become a scar, diffusion kurtosis mismatch, then you have ischemic penumbra, and this is an area of oligemia. Rapid AI is a new tool which is based on imaging, which divides the perfusion and diffusion abnormality very, very accurately in a matter of 1.5 seconds. So you have diffusion abnormality, you have perfusion abnormality. Diffusion abnormality here is 13 ml, perfusion abnormality is 155 ml, so mismatch volume is 142 ml, and this value is given to you in 1.5 seconds. So you save a lot of time, and in decide which you would normally spend deciding the size of diffusion perfusion abnormality. So this is summary of what we learned today: concept of diffusion and flare mismatch, infarct core volume and its implications on the outcomes of stroke patients, CTA collateral scoring system, single phasic and multiphasic, MRI in hyperacute stroke and how it is superior to CT, ASL versus CT perfusion, and how ASL is more important than CT perfusion because it can be repeated several times, how Don's criteria are changing repeatedly and frequently, the new aspect score and its importance in posterior fossa stroke, 4 predictors of post-thrombolysis hemorrhage on CT, on MRI and on DSA, plaque imaging and its importance in understanding the type of plaque, stable versus unstable, SWI imaging and how it is changing the way we look at hemorrhages and microhemorrhages, diffusion conducive imaging which may replace diffusion imaging in stroke patients, and PH MRI which will show you areas of benign oligemia more accurately, and role of AI in stroke and how it can save a few seconds in these patients who require prompt treatment. Thank you.